Good morning, students.
Good morning, sir. Yes, sir.
Yeah, okay. After I think after 1 month, there is a gap. After this, we are starting again our session. I think already we have finished our this thing, and then revision also finished. Then again, because few classes are left, so I'm taking another topic. Okay. So this is the first topic is the bone tumors. So bone tumors. So bone tumors. What is a tumor? A swelling which is arising either from soft tissue or bone. That is called bone tumor. Tumor. If it is arising from the bone, then it is called bone tumor. Of course, I think you must. Did you finish your pathology part? Did you finish your pathology subject?
Yes, sir.
Not yet, huh? So you finished. Then you must be knowing what is bone tumor and what are the different types, just like broadly. Especially pathological part, tissues, histology, and all. So bone tumors can be primary, secondary, two types. Hmm? Of these tumors, the primary, secondary tumors are more common because they can that is called nothing but metastasis. Metastasis is nothing but spreading of a tumor to the remote site through either lymphatic channel or blood vessels or some of that. So because many of the malignant tumors they cause metastasis, that's why secondary tumors are more common. So in the malignant section, primary bone tumors are divided into benign and malignant. So primary bone tumors are much more common than malignant primary bone tumors. Yes. In the primary, again, if you can come to primary bone tumors, they are divided into benign and malignant. So among benign and malignant in primary bone tumors, the benign primary bone tumors are more common than malignant. So if any bone tumor, how to approach? Hmm? There are different bone tumors. How to approach? You have to approach either benign or malignant. You have to approach clinically as well as investigations. Investigations include hematological as well as radiological. So most of the tumors they're visible in the X-rays broadly, and if necessary, we have to go for MRI scan, which is used for local staging of the tumors and to assess the position of the tumor in the medullary canal or degree of cortical involvement, cortical break, and involvement of nearby structures like soft tissues, blood vessels, layers, all those things will be seen by them. So, how will you locate in a primary bone tumor? This I am telling you broadly first. How do you before classifications and discussion of particular bone tumors according to the classification, I'm telling you broadly how to get an idea to just assess the bone tumor. So, DNA radiograph, if you take, you have to assess the location of that particular tumor, precise location. Then, underlying bony abnormality. What is abnormality seen? And margins, well-defined margins are seen or not. If a well-defined margin is seen, then we can think of it's a benign or malignant. If the margins of the tumor are well-defined, then we can say it's a malignant or benign. You have to answer. So the malignant,
Benign, sir.
these margins are very clear, well defined, then you can say it's a benign tumor. And cortical expansion or destruction, that is also an important thing. Whether cortex is broken or expanded or eaten away, all those things. And periosteal reaction, and then soft tissue mass. All these things can be seen broadly in the X-ray. Again, coming to the benign lesion in the radiographs, that's what I'm telling you. Difference between the benign and malignant lesions in case of X-ray. So, geographic pattern of the bone destruction must be seen very clearly. If you see the bone destruction part in benign tumors, it's a well-defined area of bone lysis, lytic area, with a sclerotic rim surrounded by sclerosis. That is the typical appearance of any bone tumor in case of benign tumors, as well as the sclerotic rim, which indicates that the bone has had time to react. Yes, bone that sclerotic rim indicates that bone is getting some reaction, and a solid periosteal reaction displacing the displaying the focal cortical thickening. Yes, there is a solid periosteal reaction. So all these things, for example, what these are the examples of the benign tumors like enchondroma, aneurysmal bone cyst, simple bone cyst, non-ossifying fibroma, and chondroblastoma. Most of the cysts are 99% they are benign tumors like simple bone cysts and all. So malignant lesions, how they are seen in the X-ray. So in a malignant lesion, permeative pattern of bone destruction. But in case of where that part our benign lesion, this geographic pattern of bone destruction. Geographic pattern means only in that particular region, well-defined, localized, well-defined lesion, which is situated in the bone. That is geographic. But this is permeative. It permeates the destruction pattern will permit to enter into other part of the bone. So destruction displays the tiny radiolucencies between the residual bone trabeculae. That is the one. And also in X-ray, the malignant tumors are poorly defined bone pattern. Already I told you. And a periosteum shows separation from the cortex. There, periosteum is periosteal thickening is seen, which is attached to the this thing only, parenteral cortex. But here, periosteum will be separated and formation of new bone. That is, for example, in case of osteosarcoma, the Codman strangle, onion skin layering in case of Ewing sarcoma, all those things. So now you must be very clear about brain tumors and malignant tumors, how to differentiate in X-ray. Example like osteogenic sarcoma, Ewing sarcoma, chondrosarcoma, all those things. Then, yeah, see, this is for example enchondroma. See, here, this is a benign lesion. What I told the few points just now about benign tumors, the X-rays are very clearly seen here. See, here it is seen especially in the metaphyses of the tubular bone, like digital bone, digits, small bones of hand and feet, and a lytic geographic lesion. So, this is the geographic lesion seen only in particular geographic area. Not here, not destroyed this part, and not came out like this. And it's a well circumcised oval lucency which is surrounded by a thin rim of radiodense bone. This well defined circumference with surrounded by sclerotic bone, rim of sclerotic bone. This one. This is this part. Okay. Now this is the simple bone cyst. I told you most of the bone cysts are again simple, benign. So the proximal humerus and proximal femur, for example, proximal humerus and proximal femur are the most important things in this case. So see, in case these are proximal femur, here the well-defined central marginated symmetrical lesion. See, this is a well-defined centrally occupied symmetrical marginal lesion, which is a metaphysis is not broader than the width of the epiphyseal plate. Here the metaphysis is not broader than the width of the epiphyseal. This is epiphyseal plate, not broader. Okay, then metaphysis is not broader than with the width of epiphyseal plate. Thin rim of non-reactive borders in the cyst. This is a thin reactive non-reactive bone orders of the bone cyst. 1 second. Hello. Sir. Good morning, sir. Sir. వచ్చాను సార్ క్లాస్ తీసుకుంటున్నా ఇక్కడ రూమ్లో. So sorry, this is the simple bone cyst, which is well defined, centrally located, especially in the metaphyseal bone, and thin rim of non-reactive bone orders of the cyst. So here you see, it is not looking like a reactive bone border. It's looking like a non-reactive bone border. Hmm. So that is the simple bone cyst. So another one is a non-ossifying fibroma. Here, see the difference. Metaphyseal or diaphyseal regions of the distal femur of the tibia, which is seen in case of distal femur and distal tibia. Especially which is seen in case of either metaphysis or diaphysis also. This is non-ossifying fibroma. The difference is it is eccentrically located. See, it eccentrically means one side. It is not occupied in the center. It is seen especially in one side of the cortex. Lobulated. These are the lobules. See, septa are seen. So surrounded by sclerotic rim. Surrounded by sclerotic rim. This is very clearly seen non-ossifying fibroma. Be you must just remember these type of identification features, because remaining things from where it arises, how it arises, age of the child, age of the adult, and all those things you can read. But identification in the case of X-ray is very important. That is a clinical approach. So this is how you have to remember non-ossifying fibroma. Well-defined, eccentrically located, lobulated, septate, and sclerotic margin. So this is the simple bone cyst, which is in the center, not eccentrically, but no septate, no non-reactive bone formation. Hmm. And enchondroma is totally different, which is seen especially in the digits, tubular bones. So this is enchondroma. So you have to identify the bone tumor according to the age of the child, age of the patient, and then play origin of the bone, whether metaphysis or diaphysis, and which bone it is originated, tubular bone, long bone, and location, whether expanded or non-expanded. All these things you have to see. So this is coming to the osteogenic sarcoma, which is a malignant tumor. Here, the metaphyseal region of the distal femur and proximal tibia. This is the most typical sites of the. These are the most typical sites of the um, osteogenic sarcoma. Highly potential malignant tumor. It is, which is seen around the age of 20 to 30 years of age group. Metaphyseal region of the distal femur and the proximal tibia, and destroy the surrounding cortexes and produce a soft tissue mass. That's what I told you in the X-ray features of malignant tumor before in the beginning, which is seen here. See this one. This is the already this destroyed the cortex, and surrounding periosteal new bone formation is clearly seen. So that is looking like a triangular shape. Triangle shape. See, this is triangle. Again, here it is a triangular. So that is called Codman's triangle. So what is Codman's triangle? If anybody asks you, you would say there is a destructive periosteal triangular new bone formation, which is here in case of osteogenic sarcoma. That is important. And especially this bone. They, of course, is it adult X-ray or pediatric X-ray? Can you tell me? Is a X-ray of the adult people or a child? This you have to answer. Are you listening or not?
Child, sir.
Yeah. How can you say it's a child? How do you say it's a child? Others not there? So because in this epiphysis and metaphysis are not fused. So in case of previous X-ray, this epiphysis and metaphysis are fused, but here there is no fuse. It's separated clearly, which you should not be confused with the fracture. If there is a fracture, if the child fall down and had same fracture here, means how do you differentiate? The fracture lines are irregular and serrated margins very clearly seen. That's why you must be able to identify the fractures in children as well as in a fracture, or whether it is a fracture or whether it is a normal bone. That's what. So they coming to the Ewing sarcoma, which is particularly pertain to the child. So which is most commonly seen in diaphyseal region. See here, this is the epiphysis, this is the metaphysis, this is the diaphysis. So this is a destructive lytic lesion with permeative pattern and onion skinning. See here the layer wise appearance. This is one layer, this is one layer, and this is one layer. The lamellated appearance. This is called a typical feature of the Ewing sarcoma, onion skin layer, onion skinning appearance. So coming to these are about a broadly how to identify X-ray. Hmm? So now coming to some other discussions. Yes, yes. So now, are you able to see now?
Yes, sir.
Able to see? Okay. Then, when we come to the bone tumors and tumor-like conditions like osteosarcoma, osteoid because here I am not touching the classification. Classification is broadly different many types based on staging, based on origin, based on site of origin, based on cell of origin. So many are there. Those things we will discuss in the next class. Anyway, but this part is osteosarcoma, osteoid osteochondroma, and non-osteochondroma. They are tumor-like conditions. We cannot say they are not tumors. They are tumors, but some of them variations are there in this. They are tumor-like conditions also. So see, bone tumors are diverse in their growth, gross and morphological features, and range from benign to rapidly fatal. I told you just now. This diversity makes it critical to accurately diagnose and stage of the tumor. Timely, accurate diagnosis allows appropriate treatment to so that the patients cannot only survive but also maintain optimal function of the affected body part. That is timely diagnosis. Either by patient, of course, patient cannot diagnose, but if the patient had any minimal symptoms, if he feels any this thing, if he properly approaches to the proper treatment center, definitely, bone tumors can be diagnosed very early, either by bone scan, nowadays PET scan, so many things came. So these by these things, so we can early diagnosis definitely always very much useful, even though whatever it is fatal. So it is classified based on I told you based on so many things like bone tumors are classified according to the cell of origin and and the substance they produce according to whether matrix producing, whether fibrous tumors in which the fibrous tissues were very much high. Among the benign tumors, osteochondroma, fibrous cortical defects, that's what are more frequent. Excluding malignant neoplasm of the marrow origin, osteosarcoma is the most common primary cancer. If anybody asks you which is the most common primary malignant tumor of the bone, well, it means then you will have to say osteosarcoma, followed by chondrosarcoma and then Ewing sarcoma. Okay. And the precise incidence of the tumors is not known because many benign lesions are not biopsied. That's what say. In the world, if many benign lesions, because patient may not will to go and to undergo for biopsy. If once you say, okay, this is looking like for assurance, this is looking like normal, benign, it's not so much dreadful tumor like that, the patient will neglect. They will not go for biopsy. So like that, so many cases are missing. So that is one thing. And that's why biopsy is not being taken place. So benign tumors outnumber malignant tumors by at least several hundred folds. Benign tumors have their greatest frequency within the first 3 decades of life, whereas malignant tumors are much more common in the elderly people. In the of course, coming to the US study, so many every year, so many cases are diagnosed. Of course, it's not related to us. And a clinical presentation. Clinically, bone tumors present in various ways. The more the common benign lesions are frequently asymptomatic and are detected as an incidental finding. Yeah, that's true. Because the patient comes for something. He will come for some bone pain or he will be having some minor knee sprain or ankle sprain, elbow sprain like that. And when we take X-ray, incidentally we will see. That is one of the most important thing in which is to remember. And many tumors, however, produce pain or noticed as a slow growing mass. Sometimes the first hint of the tumor's presence is a sudden pathological fracture. This sentence you must remember. If the patient had sudden pathological fracture, whether elderly people or middle-aged people, for small incidents, just if he touches his If he touches this thing, shoulder or elbow to the wall, if he gets fractured, means there is definitely some suspicion of tumor. So sudden pathological fracture is the most common first hint of the tumor. Okay. Then how will you diagnose? Radiographic analysis, already I told you, which plays very important role in diagnosing bone tumors, in addition to providing the exact location and extent of the tumor. And then ultimately, in most of the instances, biopsy, not only the X-ray, of course, X-ray, you can see the just broad identification you can get, whether benign malignant, if it is malignant, how far it is extended, what type of tumor, all these things. So for that, again, we have to go for further radiological investigation like MRI. MRI will tell you whether presence are spread in the soft tissues, blood vessels, other things, and the tumor portion eroded the bone and all. And another radiological feature is just body isotope bone scan. Isotope bone scan will tell you whether this bone part, this tumor has spread to another part, any other bone, bone to bone or soft tissue to bone, anything. That one. And not only these things, because meticulous diagnosis and accurate diagnosis is very important to give proper treatment. Otherwise, the treatment will be failed. So, again, you need to diagnose properly. In that case, you have to go for biopsy. Biopsy means you will take out some tissue by means of operation and send it for so many examinations, histopathological. So these are very important things. Osteosarcoma is defined as a malignant bone tumor, which is a malignant tumor in which the cancerous cells produce bone matrix. You must remember. How do you define osteosarcoma? It's a malignant mesenchymal origin, mesenchymal tumor in which the cancerous cells produce bone matrix. Osteosarcomas occur in all age groups, but have a bimodal age group distribution. I mean, 75% occur in patients younger than age 20 years. Of course, some osteosarcomas will be seen after 40 also. That's why it's a bimodal bone distribution, age distribution. So most of them are less than 20. In adolescents, and about half of them arise in the metaphysis, around the knee. Yes. Either in the distal femur or proximal tibia. These are the sites of greatest skeletal growth activity. I mean, that's why distal tibia, distal femur, and proximal tibia are the places of greatest bone activity. That's why there appears to be more. In persons over the age of 25, the incidence of flat bones and long bones are almost equal. So this one, see, 60% in this are seen in case of distal femur, proximal tibia, and 15% in case of proximal femur, and 10% in the proximal humerus, and 8% in some flat bones, jaw, and all these things. So osteosarcomas are typically present as a painful and progressively enlarging masses. Painful and progressively enlarging masses. So sometimes they are very fast reacting. So after the diagnosis of primary tumor, within 3 months only it spreads to the other parts. So very aggressive. Sometimes sudden fracture of the bone is first symptom. A grossly osteosarcomas are bulky tumors that are gritty, gray white. If you see the cut section of the osteosarcoma, they are the bulky tumors that are gritty in sensation. If you just cut something like which one, some fibrous fruit, for example, pineapple, such fruits, if you cut, what sound you get? Gritty sensation. So such that it if you take the cut section, it appears like that. And also it's a gray material looking like a gray white color, and often contains areas of hemorrhage and cystic degeneration. The formation of the bone by tumor cells is a characteristic of osteosarcoma. That's why the formation of the bone by tumor cells will form a new bone. That's what I told you just now. Codman's triangle and all. That is nothing but this only. So this is the characteristic feature of the osteosarcoma. And radiographs of the primary tumor usually shows a large destructive mixed lytic and blastic lesion. Why you are saying it's a lytic and blastic? So here blastic is a newborn formation, lysis is destruction. One side destruction is going on, one side again newborn formation will take place. So that in this case, rather than the destruction, newborn formation is more. That's why this type of cardiac Codman's triangle is said. The tumor frequently breaks through the cortex and lifts the periosteum, resulting in a reactive periosteal bone formation. The triangular shadow between the cortex and a raised ends of periosteum is known as the radiographically Codman's triangle. So, the triangular shadow between the cortex, this is the cortex, and raised ends of periosteum, this is the elevated periosteum. So, this part is known as the Codman's triangle and is characteristic but not diagnostic. It's a characteristic feature. So another one is the central osseous. There are different types of osseous. Central. See, the this one is seen in the central region. This one is seen in case of central region, a destructive lesion which is seen in the metaphysis on this AP view of the knee in a young teenager with a pain. This one. So, this is the picture of the MRI. MRI showing both less shows of the soft tissue extent of the tumor because here this is not much extended into soft tissues. So, this portion. Another tumor is the osteoid osteoma. Yes, it is a benign tumor. It is one of the most common tumor in which the tumor less than a 2 centimeter and greatest dimension usually occurs in patients in their teens and 20s. Of course, between teen means 14 to 16 years, and in the 20s both. In fact, 75% of the patients are under age group of 25. So these bone tumor of less than 2 centimeter. Osteomas can arise in any bone but have a predilection for the appendicular skeleton. 50% of the cases involve the femur or tibia, where they commonly arise in the cortex. Osteoid osteomas are a painful lesion. Yeah, see, even though it's benign, it's a painful. The pain is caused by excessive prostaglandin E2, E2, which is produced by the proliferating osteoblasts. It is characteristically seen, occurs at night. Pain occurs very characteristically at night and is dramatically relieved by the especially one drug called aspirin. Hmm? Aspirin. So these are the very clinical typical features. Pain occurs at the night, hmm? and let's say there is some bone nodule somewhere, and relieved more night pain and relieved by aspirin. Then we can think of osteoblast, which is very common to me. So this is osteoblast. See in this region. A lateral view of the proximal tibia showing very dense lesion in the posterior cortex. So a darker central area contains a white nidus. Yes, this is a darker central area showing a white nidus. This tibia. See how it is seen. So this lesion is in 20 years old man caused pain in this area, relieved by aspirin, and after that they have taken nuclear medicine. So that is bone scan. Bone scan in a different patient with a osteoblastoma in the left lower tibia shows increased activity at the site of the lesion. So there is increased activity at the site of the lesion. This is the here the lesion. Okay. So osteoblastoma, especially those that are arise in the beneath the periosteum, usually elicit a tremendous amount of reactive bone formation that encircles the lesion. See, this is very rare. This type of osteoblastoma, which arises from beneath the periosteum, under the periosteum, is a tremendous amount of reactive new bone formation is seen, and the actual tumor known as the nidus, which manifests radiographically as a small round lucency that is invariably mineralized. See, in this case, this specimen is showing a round radiolucency with a central mineralization represents the lesion and is surrounded by abundant reactive bone that has massively thickened the cortex. This one, all this is. Hmm. So the osteomas are considered benign and are normally treated by conservative surgery. Conservative only. Sometimes surgery. However, why here we call this as a conservative surgery means just you can remove that lesion, that's all. It will not recur. Or sometimes it may recur, again remove, again. But you no need to go deeper into the tissues, or debride, remove that, this. All involved portions, uninvolved portions, like that. So that's why it's called conservative surgery. Hmm. However, there is a possibility of malignant transformation. These rare except when treated with radiation, which promotes this complication. So this is about osteoid. Then coming to another one is osteochondroma, which is also a benign tumor, which is very quite common. Exostosis, I think you must have heard exostosis, is a benign cartilage capped outgrowth that is attached to the underlying skeleton by a bony stalk. I will show you the X-ray. It is relatively common lesion and can be solitary or multiple. So multiple osteochondromas become apparent during childhood, but solitary osteochondromas are usually not diagnosed until late adolescence. Men are affected by 3 times more than the women. They arise from the metaphysis near the growth plate of the long tubular bones, especially the knee part. They arise from the metaphysis. Okay. So osteochondroma, this one, see in the distal part of the tibia, especially around the ankle. See in the posterior aspect, this one is a slow growing mass which can be painful. Okay, slow growing mass which is a painful. If they impinge on the nerve or the if they when it is a painless normally. Suppose if it is see how long it is extended, it is projecting like a horn. So if it is pressing some part of the blood vessel or some part of the nerves or some other tissues, or sometimes here they get fractured because of some injury, then it causes the pain. So these are the causes responsible for the pain. These are the factors responsible for the pain in case of osteochondroma. In many cases, they are detected as especially I told you incidental finding, especially though two bone tumors are very commonly seen. Incidental finding, if you take X-ray for one thing and you will see another thing like this, especially this osteochondromas as well as bone cysts, these two. So another one is a fibrous cortical defect. Already we discussed in the X-ray. That is a non-ossifying fibromas. Fibrous cortical defects are very extremely common and found in the 30% to 50% of children. They believe to be developmental defects rather than neoplasm. So the vast majority which arise in the metaphysis of the distal femur and proximal tibia and almost as bilateral or sometimes multiple. Usually, the fibrous cortical defect size is of 5 to 6 centimeters. There it is called non-ossifying fibroma. That yes, I will show you this one. Here, the fibrous cortical defects and non-ossifying fibroma. Both the fibrous cortical defects and non-ossifying fibromas produce elongated, sharply demarcated, radiolucent lesions that are surrounded by a thin zone of sclerosis. See, here it is elongated. And sharply demarcated, but then you cannot see lobules. Lobules are different. So here you are not seeing any lobule. So okay, so these are about bone tumors in a broad how to detect, how to differentiate according to the X-rays, as well as what are the bone tumor-like conditions. Just now we discussed non-ossifying fibroma, and then this another one, non-ossifying fibroma, as well as this multiple cortical defect, exostosis, all like bone tumor-like conditions. So already that's what today we have discussed like most of the softish benign tumors. So this is about bone tumors today class, and next class we discuss classification and we will discuss some of the secondary tumors, because this bone tumor is not a very big topic, so we cannot complete in 1 to 2 classes. I think we need to take 2, 3 or 4 classes total for the bone tumors. Then only you can remember and you can grasp. Okay, so this is about this one. So by this we are going to stop our class today. So read and come for the next class.